ECMO, specifically talking about indications with using ECMO in patients post-cardiac arrest, cardiogenic shock, and severe cardiac hemodynamic compromise that has been unresponsive to other mechanical devices, i.e. balloon pump, that's when we see that drastic increase of ECMO. Now, the good thing is that things have gotten a little bit smaller. Devices for ECMO have gotten easier, the circuits themselves. However, the survival through the procedure to discharge is marginal at best, between 29 to 42% with ECMO, so it's not great. It is obviously a very valuable resource that we do have to support these patients, but outcome data looking at discharge really is not very high. Now, as a result of the less than optimal outcomes and physiological changes that we can see due to the use of ECMO, such as ventricular distension, balloon pump has often been combined with ECMO, and you may see that increasing more often. Now, MAN 2014 does state that while neither of these devices alone can support these severe situations with our patients, such as ventricular distension, it's a synergistic approach of the combination of therapies that we're really starting to see the benefits for our patients. And that was echoed again in 2017 by Newting and Worden, really saying, taking more of an editorial approach of the review of looking at balloon pump and ECMO, saying, is 1 + 1 2, or do we get more from that when we combine the therapies? Now, in looking at mechanical circulatory support, cardiac support, we really have a broad range of devices that we have. We can start on the balloon pump side and build up towards peripheral ventricular assist devices, ECMO, ventricular assist devices, whether RVAD, LVAD, BiVAD. But really you're starting out with a balloon pump. That's going to be that first step of mechanical support. And we all know that we typically get a cardiac output increase of anywhere from about a ½ liter to a liter per minute. Now, balloon pumps we know are easy to use, so it has low technical demands. It is very cost effective, but it is more of that short-term type of therapy. It is that initiation of therapy. Now, in the first 30 minutes, Ramanathan was able to show that, we really need to think about, if we don't have full hemodynamic support in the first 30 minutes on a balloon pump to about an hour, you really want to think about escalation. What is the next step? Have I exhausted everything? Do I need to move on within that mechanical assist world? And looking at implantation of, say, a peripheral ventricular assist device, you can have an increase anywhere from approximately about 1.5 liters to 3 liters from those PVADs, but really we're talking about that ECMO and adding ECMO. Now, I'm not going to talk about LVADs today. We're really going to stop with those first three and truly looking at balloon pump and ECMO combined, because we all know that a balloon pump and an LVAD, there's no indication for that. You don't pair those two devices together. So we're really going to talk about those short and midterm type devices and situations. And when we're talking about this, sorry, I turned my own page, forgot to turn the slide. When we talk about the indications for use and duration, again, we're looking at short-term, midterm, long-term. Why, what device are we using in what situation? And when we talk about, the acute support of cardiogenic shock or cardiac arrest, we're really looking at our short-term type devices, our balloon pumps, adding an ECMO to support that patient, peripheral ventricular assist devices. Midterm, bridge to transplant, bridge to recovery, none of these are indications for balloon pumps specifically. But we all know that these can be patients that we have a balloon pump in and we're escalating therapy, and that balloon pump may maintain over the course of the added devices. So it just kind of depends, again, on the long-term goal of the patient, what the process is going to be. Destination therapy, those are our surgically implantable VADs. Now, in your own situation, in your own institution, if you don't do those type of procedures and utilize those devices, you may have a patient on a balloon pump and ECMO and then transferring that patient to go into a facility to have one of those implantable devices, because you are looking at a destination therapy type of situation. Now, balloon pumps can sometimes be used as a vent for the LV during ECMO, and we're going to talk about how that is done and also some of the benefits that we can see with the combination and really looking at the venting of the LV. So in combining the support of balloon pump and ECMO, number one, you have a lot of stuff going on in a room. But really what I want to talk about is kind of the decision tree as to when to maybe add and escalate. Now, this is a really nice schematic that we do have, and we were able to access this. And it's looking at those patients who we've exhausted all of the initial therapies on. So we've gone through our, optimal volume loading. We've looked at inotropic support, ventilatory support, reperfusion times, give them a longer, more prolonged time with reperfusion, adding a balloon pump, but if that still is not enough to meet the metabolic needs of our patient and we're still not seeing hemodynamic stability, that's when you ask, is my patient viable? Do I have a viable patient to move on to implanting something else? And I'm just gonna work on the left side of this little schematic here, and that's when we're gonna add ECMO support. So we're maintaining everything that we've done in that top box between our medical therapy, our balloon pumps, inotropes, but then we add ECMO. Patient is on ECMO. The question is, we're not gonna leave anybody on ECMO. The next step is, do I have cardiac recovery? If I am looking at a patient that is showing signs of cardiac recovery, then I start to wean the ECMO. And I will go through some of the current data that is showing that ECMO weaning is supported, and we do have improved weaning with the support of a balloon pump that has been left in over the course of that ECMO run. Now, if I don't have any kind of cardiac function recovery, then the next question is neurological support. Do I have a positive neurological testing? Do I have full organ support? Do I have full organ function? Then we're looking at potential transplant or ventricular assist device for destination therapy. Again, balloon pumps are now kind of out of the question. So I'm looking more at that left side here. And these indications for the combined therapy, specific indications here, we all kind of can picture the patient. Even if you don't have an ECMO program, you know the patient where you've done everything that you possibly can do. They're on a balloon pump, but maybe that's the most mechanical support you have in your institution. Those are patients you're sending them out now because they need something more than what you can offer. It could be somebody in cardiogenic shock, it could be post-arrest, or just despite maximal medical therapy, and balloon pump is just not enough. You may have problems weaning from bypass. This is where you can add those devices should you need to. And the other ones, just going down the list, these are the basics where you could see the combined efforts after we've exhausted everything else. That's when you're gonna move up that and escalate that mechanical circulatory system tree, When you look at the timing of the devices, so not timing of a balloon pump inflation and deflation, but timing of initiation of therapy. Now, if you've already had a balloon pump intact and in the patient, you may need to add ECMO to generate a higher cardiac output or stroke volume for the patient because there wasn't quite enough to meet their needs. Another time could be, if the patient fails to wean from bypass and that LVAD or ECMO is needed for the generation of the cardiac output. But if you have an ECMO first and you want to add a balloon pump, you could be adding for pulsatilities, that pulsatile flow from the inflation, deflation of the balloon catheter, and you could also be adding it to help vent the LV or decrease the distension of that left ventricular area. When we talk about that, now we're really going to be looking at the comparison of mechanisms of action, and through balloon pump and ECMO, a lot of things are going to be opposite. One thing is going to help it, the balloon pump may help something, the ECMO may kind of fight that. But the two I really want to focus on are coronary vascular resistance and MVO2. Now, balloon pump, we all know, helps to decrease myocardial oxygen demand, and we do have a decrease as well with our coronary vascular resistance. But what ECMO can do is directly opposite of that. So balloon pump is going to be able to help counteract some of the negative effects that we can have with ECMO, and it is going to be currently supported with our research that we're going to go through. Now, review of current research, as I said, we're going to show how there is increase in successful weaning from ECMO with the support of a balloon pump. You do also have a decrease in your coronary vascular resistance, increase in coronary flow and cerebral flow in some patients, decreased risk for pulmonary edema, and then 3 of the studies to support these are listed below, and we're going to go ahead and go through those now. Now, Matter-Sheehan in 2009 and 2011, so on the left side up here, this is looking at coronary blood flow increase. Now, obviously, there's going to be an increase in coronary blood flow with the diastolic augmentation or inflation of the balloon catheter. But the other mechanism of action that was noted here was that with the decrease of coronary vascular resistance, because the balloon deflation helps to unload the left ventricle, obviously, if I decrease coronary vascular resistance, it is easier for that diastolic augmentation or inflation benefit of the balloon to get even higher coronary blood flow. Because if I decrease the resistance, it's easier to get blood through there. So it is kind of that synergistic, again, effect from inflation and deflation benefits. And with that study, it did show all patients had an increase of coronary blood flow and a decrease in coronary vascular resistance. Now, what Yang wanted to look at was more of a cerebral blood flow type of increase. Where can I see an increase in my cerebral flow with balloon pump and ECMO combined? Where may not I see that? And what was interesting here is that it was a mix. In patients on VA ECMO alone, if there was a pulse pressure greater than 10 millimeters of mercury, that patient did not get a benefit from the balloon pump being added looking at cerebral blood flow. It was the patients who were on ECMO alone, VA ECMO alone, had a pulse pressure less than 10. Those are the patients that got to see the increase in cerebral blood flow. So although everyone got to see an increase in your coronary, not everybody gets to see a benefit from the cerebral increase as well. So it depends on what we had kind of pre-insertion of that balloon on ECMO. With Brechot, what was looked at here was the hydrostatic pulmonary edema that we all know can happen when patients on VA ECMO. Now this was specifically with peripheral cannulation for VA ECMO, and there's about a 30% drop in hydrostatic PE when you have a balloon pump added with that ECMO run with peripheral cannulation. So it does have a big increase with that decrease in afterload. You're going to help decrease the distension of that left ventricle. And the results that Brechot got, now it was somewhat of a small study. I think there was about 110, 105 patients overall with combined efforts of balloon pump and ECMO there. But what was interesting was that Tepper in 2017 was able to establish and recreate these same results. So it was confirmed in a separate study, separate institution. So we are seeing that we do have that decrease in the pulmonary arterial pressures, decrease in risk for pulmonary edema, hydrostatic from ECMO flow, and just that distension of the left ventricle. So it all goes together. So not only am I getting increase in coronary blood flow, I have a decrease in coronary vascular resistance, I have a decrease in left ventricular distension, and it's really thinking about who's going to be able to benefit from that, and then looking at the current research and what supports that. Now, the question still remains. That all makes sense to all of us. Everyone's kind of nodding their heads along as I say all of this. But the question is that really going to improve our survival outcomes? And there is a mixed bag out there. There are definitely studies that are not showing any kind of increase of survival outcome, but there are some that are trending towards that. One thing that I think is happening is that we do need more data to collect. There does need to be more research. We do need to look at this more. And when we talk about those studies that have not shown any outcome improvements, so any survival outcome improvements, a couple up here that I want to highlight are Lynn and Raston. They had the largest number of patients of the combined therapies, and while neither confirmed a decrease in mortality, Raston was able to confirm that the balloon pump use was associated with a strong trend towards improved outcomes, especially in our older patients, so patients who are older than 70 with a list of comorbidities associated. Rowe was also able to confirm that there was a benefit for successful weaning from ECMO with balloon pump support. However, there is no decrease in mortality. So there is that combination here, but most of these studies concluded that a larger randomized controlled trial is necessary with a larger number of patients to be able to truly see that increase, and it may confirm then that there is a survival benefit. So everyone here did confirm that we do need more. Now, these meta-analyses here, these two listed, did not show any improvement in outcomes, but it is important to note that the ASO study, which is larger than both of these meta-analysis, was not included here. And when a newer analysis is done, the results may show an improvement of outcomes to survival. But now moving into those that do show an improvement to our outcomes. Now here, Ma was able to confirm in 2014 again that more patients were weaned on ECMO or from ECMO with balloon pump support as compared to those who did not have balloon pump support. So he did have that increase of successful weaning with a combination of therapy versus just ECMO alone, trying to wean. So it did help aid in that DC of the ECMO. The ASO, the Japanese registry, this provided data on over 1,600 patients. So this is the largest conglomerate look of a group of patients, and these were all inpatient Japanese study done from inpatients diagnosed with cardiogenic shock. And they found that the use of the balloon pump did result in a significant reduction in mortality and a higher likelihood of the patient weaning from ECMO. So they had both sides. They saw both an improvement in overall outcomes and an improvement in weaning from ECMO. And Brechot, again, was able to show that although there was a reduction in the pulmonary edema, there was a strong trend towards decreasing mortality. But again, that study was somewhat small. It was only 259 patients total. So, and that was both groups. So the balloon pump and ECMO combined group was 104. So again, smaller patient groups, so we do need just more data. We need more data to be able to take a look at that. Now, as we've gone through, now we're going to talk about how you're actually going to manage the balloon pump when your patient is also on ECMO. There are some considerations that you need to take into thought when you have the combination of therapies. And one of the things is a lot of the pumps out there now, whether it is an Aero pump, Teleflex pump, or a competitor's pump, all pumps have a level of automaticity to them. So a lot of the pumps are able to do a lot of the daily functions, a lot of the normal things that we're used to, and we can stay in our autopilot mode most of the time. But when we have an ECMO combined, there's a new, it's a new ball game. You have an entirely new device that is changing things that a balloon pump normally looks at. So we really have to think about how we're going to manage the patient on that pump. Now, when we talk about autopilot mode on the Aero systems, this is where the basic functions of the pump are going to be selected by the pump, which is going to work okay if you have good signals to give the pump. One of the things that we always talk about is give a balloon pump good signals to work from, and you'll get good pumping out of it. Good triggering, good timing. You just need it to be stable. We all know that a lot of times a patient on ECMO does not have a stable EKG rhythm. They can have a lot of aberrancies, a lot of ectopy, a lot of irritation going on in that EKG, so that may not be the best option, and that's what autopilot tends to look at. So when we go through this list, when you're using autopilot with an ECG signal only, because APs are usually flat when you're talking about a patient on ECMO on a balloon pump, you're going to be talking about a Weissler timing, and that does optimize the length of inflation if you can push deflation to the R wave. We can talk about the settings on the pump specifically, but you all understand that if you are not garnering consistent support on your balloon pump in autopilot mode, go into operator mode. That's why it's still there. It will forever and always be on a balloon pump, so you can manage that as you feel necessary for your patient at that moment in time. Now, most of the time, I'm instructing nurses on how to use balloon pumps, what balloon pump therapy is, and you all know that nurses don't necessarily love operator mode. We love autopilot mode. We like the automaticity of it. Perfusion, you guys are always my go-getters for operator mode. You want to have control of that pump, and this is a perfect opportunity to then have control of that pump for specific reasons, because autopilot may not be the best. So when you're talking about triggering for the balloon pump, forcing it to go from an ECG trigger is most likely going to be ideal if your ECG is regular, if it is a nice stable EKG rhythm and rate. If not, you can use internal. Now, internal trigger on a balloon pump is wonderful. It's very consistent. It is very regular. However, if there is any kind of native contractility of that LV, you want to be cautious of using internal, because you don't want to be inflating a balloon against an LV that's trying to contract and eject blood forward. You just don't want to fight the natural progression of recovery. AP is generally not going to be recommended because typically you don't have an AP waveform. Patients on ECMO, the flows are going to cover that up if there was any kind of forward flow. Now, timing considerations, in looking at timing considerations for the balloon pump when you are on ECMO, a couple of the things that I want to focus on, if you're in operator mode, we always know that it's not just the inflation push. It's not just that diastolic augmentation. It is the duration of inflation that's really going to be beneficial. I was just having this conversation prior to my talk, and one of the nice things that you can do on your Aero pumps is put it into what we call our AFib trigger. That will actually extend your deflation to the R wave, and then you have a longer, more consistent inflation time that actually matches true to the cardiac cycle. In internal trigger, in operator mode, obviously that's just going to be taking up, inflation is about halfway into the cycle, into that rate. So inflation duration is about 40 to 50% of the available rate that you're pumping at. And on an Aero pump, you can vary that heart rate in internal anywhere from 40 to 120. So you have a lot of play with that. Now, timing considerations, summary, and advantages. If you would like to, I'll leave that up here for just a second, but if you would like a little bit further look into this, please feel free to stop by the booth. I'll have this available. We can kind of talk about it and look at that. But to go through is just a little bit time-consuming. But that is available. That is just a quick summary and the advantages of using the balloon pump in certain ways. Now, when we talk about considerations of use of the fiber optic catheter on the Aero balloon pump, fiber optic catheters for us are a very high fidelity signal source for the AP on our balloon pumps. And the nice thing about an Aero balloon pump, regardless of the source of your arterial pressure waveform, is we can actually see and recognize a 3 millimeter pulse rise on your AP waveform, and that can be utilized for triggering. Now, on a basic standard balloon catheter, you can sometimes have some dampening to that arterial waveform, and it's not high fidelity of signal as our fiber optics. So the fiber optic signal, when using with ECMO trying to wean, you are going to be able to recognize and pump off those very small pulse waves, so it does aid in weaning. You can start using that and really getting that true timing that you're hoping for. With ECMO options, as you lower the flow rate to allow the native myocardium, you allow that native ventricle to contract, you can see those tiny small pulse waves now on the fiber optic signal on the aero systems because it does recognize such a small pulse wave. Obviously, you're going to be monitoring consistently your mean arterial pressure and your cardiac output to make sure that the support is still adequate for your patient. And just because your patient may have a balloon pump with ECMO doesn't mean you treat your ECMO any differently. If you're trying to wean ECMO and the patient doesn't seem to be tolerating it, go back up on your flows. It's common sense. It doesn't change just because you have a balloon pump in. You still manage it the same. You're just going to get some of the benefits there that the balloon pump can help support as you do wean. Now, hemodynamic assessment, again, you're going to be going through and continually looking at your pulse pressure. That's going to be generated by your balloon pump from your diastolic augmentation, which is obviously going to support your coronary blood flow. Deflation is obviously going to help with that LV distension, decrease that afterload, and then you can have a decreased coronary vascular resistance, which again will help to increase your coronary blood flow. MAP is one thing that we're always going to be looking at, and you do want to see that increase and just support of that as you are weaning ECMO and maintaining on your balloon pump. Now, weaning considerations, the best trigger you can be in for weaning is going to be your ECG because that's going to be very stable. Your AP as you wean may still have a little bit of inconsistency to it just because you're trying to wean your ECMO, but your ECG is going to be much more stable and it's synchronized to what is naturally happening with a patient. So as you wean your ECMO, your balloon pump should be synchronized to your patient, whether on ECG, and if you have a stable pressure waveform towards the end, then you can go ahead and use that to trigger from if you so need to. But you do always want to be synced to what the patient is doing. So in summary, just know the therapeutic goal. Why are you combining therapies? What is the hope here? If you're in a facility that does not have transplant or an LVAD program, but you do have ECMO as your backup, that may be your option to stabilize that patient to get them onto the next facility, to have that ventricular assist device implanted for long-term support, destination therapy, things like that. You also want to know that you want to synchronize that balloon whenever possible to what is going on with your patient internally, so physiological triggers are best, and then using the appropriate trigger based on your patient condition. Stable EKG, use your EKG. If not, go for internal and operator mode. Thank you so much. I appreciate it, and I welcome any of you to stop by the booth.